Good vision is not the same as clear sight. Let me say that again. Good vision is not the same as clear sight. So if you're a little confused about what that statement means, then stick around, because in this video, I'm going to be talking to Paul Graham, who is the owner of Harmony Vision Care, Optometry, and vision therapy, one of the leading providers of vision therapy on the Gold Coast, Queensland, Australia. So we'll also be talking about myopia control, ortho-keratology or ortho-k, vision therapy, and a lot of other topics as well. So first of all, who am I? My name is Paul Salloway. I'm the owner of Optics Digital Marketing. We're an agency that helps independent optometry practices to grow. So hello, Paul. Hi, how are you today?
Good, thanks, Paul. Yourself?
Very good, very good. Thanks for joining us. So to kick us off, why don't you tell us a little bit of the backstory of Harmony Vision and yourself?
Yeah, look, I've been an optometrist for 30 years and I got an interest in the kind of work that we do within optometry as a patient first, as a teenager, and thought this was a great field to get into, and was introduced to a way of practicing optometry that did a lot more than just prescribing glasses and being able to really help people through vision therapy. And eventually that led to me and my wife setting up the practice on the Gold Coast 20 years ago. And we had two specific intentions on opening the practice: was to be able to provide what we like to call gold standard vision therapy, having an actual dedicated vision therapy room, being able to, I think we're one of the first practices on the Gold Coast to buy a topographer, which allowed us to do complex contact lens fitting and ortho-k. So from the outset, we really wanted to make sure that we kind of were providing something of really different from what was out there already.
Fantastic. All right. Well, let's talk about this statement that good vision is not the same as clear sight. Now, I'm stealing this from your website, by the way, so I think you've probably got some thoughts behind this. So tell us what this means.
Yeah, look, a lot of people, when they talk about good vision, I think what they really mean is good sight. And so the words vision and sight are used interchangeably, but we tend to look at vision being the whole thing that you do with your vision, what the brain is using to understand the world around you. And whereas sight is more just what we can measure from the bottom line on the chart. And it's such a small part of the overall visual process that it's so easy to overlook how people can run into trouble when their vision's not working well, despite maybe passing, the bottom line of the chart, being able to see 20/20 or 6/6, as we say in Australia.
And so, I think a lot of people, when they think about eye tests or eye exams, they do think about the eye chart, reading the letters. But as I work with more optometrists, and I learn that there's a whole lot more that goes into that. And in fact, you can even distinguish between comprehensive eye exams for adults and comprehensive eye exams for kids. I think there's maybe some different approaches in there. But anyway, could you tell us a little more about when you do a comprehensive eye exam for children, what are some of the things that you're checking for?
Yeah, look, and as much as we want to pay broader attention to the whole visual process, and I don't want to ignore sight, as it's still an important factor, but like I said, it's a very small part. So we do measure things like sight and what prescription is, and making sure that your eyes look healthy. But what we want to look at, particularly with kids, and this does extend into adults because they were once kids and they carry a lifetime of vision problems sometimes without realizing it. And so a good part of what we're wanting to assess is, how does this person use their eyes to learn, to move, to interact with the environment? And so we're looking at things like eye movements. How well can they move their eyes free of their head and their body? That's an important part actually in sight. In order to be able to look at fine detail, you need to be able to move your eyes accurately. So eye movement measurements are a very important part that we want to look at with kids, and it's a standard part of our exam. The next phase is, how well do you keep the two eyes working together? We've obviously got two eyes, but we only see one thing, and that's a very complex process of the brain integrating the information together. And that's a learnt process that we develop, and we want to make sure that we understand how well that's developing over time. And when we get into school age, there's a lot of pressure on the visual system, and that interaction between the two eyes and how we keep things clear can be thrown out. And so we really want to, again, make sure that we're comprehensively measuring that, because again, that's something that may not be picked up by being able to read the bottom line on a chart that's out in the distance.
Right. So as a parent myself with school age kids, I understand it's like really important that your children, can see, can use their eyes well while they're at school. So can you talk about like some of the stresses and like some of the activities that kids really need to have good vision for? Like I've read somewhere that between 70 or 80% of the learning input that kids receive at school is actually through their eyes. So it's obviously a very important sensory
Yeah,
channel for them.
they actually did a study in Brisbane, and the stats were something like 70% of a child's day is spent in a highly visually demanding environment. So even if the activity that they're doing is not specifically considered visual, it still involves a fairly high visual demand. And the other 30% is lunchtime. So pretty much the entire time they're in class, they've got high visual demand. So you've got lighting, you've got devices, and even just near work. I mean, we talk about digital eye strain affecting 80, 90% of adults now. Well, back when I was at school and devices were, I think I was the only kid with a computer, thanks to my father, but, the computers were highly unusual, and eye strain was something that was still around, but it was more if you did a lot of reading and a lot of writing and those sorts of things. Whereas, even someone who's not a reader is still connected to a device. And so that high near visual demand, I mean, basically you've got lots of two-dimensional surfaces up close, sitting still, with a human visual system that's designed for moving through a solid 3D space. And so we've got to expect that if we do that for hours on end, that things are going to change, particularly with a visual system that's still developing. And so a lot of that near-based tasks are what are quite demanding. And they're learning at the same time. So there's a big demand on the cognitive process of vision while they're also using other cognitive skills. And so there's a lot of energy being burnt there.
And so we started off by saying that that there's more to vision than just clear eyesight, and I believe that like a lot of schools, they do actually do like sight screening. But do you feel that like most educators and even parents for that matter know how to pick up the signs that a kid may have maybe in need of some vision therapy? Like do you think educators are fully aware of the symptoms and the indications that kids may be having some visual issues?
Yeah, probably not enough. And look, site screenings certainly have a place. What they're designed to do, if we understand what they're designed to do, and therefore we can understand what they don't do, they're designed to pick up the 3 to 5% of children who might have what we call a lazy eye or an eye turn, or a big difference in the prescription between the two eyes. So you can have one eye that's not seeing well, without a person outwardly showing any signs or symptoms, or as a child certainly not being aware of it themselves. And that's only just a small part of the population, and they're very important things to pick up early. But again, it's for the 5% that it applies to. Whereas a lot of the vision problems that impact people who have more normal, just 20/20 in each eye, it's really easy to overlook the symptoms. And I just don't think that that a lot of people are aware of it. I don't know how much it's part of educators' training anymore. You certainly get some teachers who become aware of it as part of their experience. And certainly, again, it goes back to the whole, all we talk about is sight, and that's what's in people's minds. So there needs to be a lot more discussion around the kind of symptoms for sure. That might indicate that someone's not seeing as well as they could, or using their visual system as well as they could for learning.
So what would be some red flags to look out for then if you're a teacher?
Yeah, look, I like to look at two brackets of symptoms. And so a lot of the time when I'm talking to parents and teachers is that we have what we call eye-related symptoms. We have what we call performance-related symptoms. And so your eye-related symptoms are ones where we might all agree fairly easily, that kind of sounds like a vision problem. And so they might complain of blur, they might complain of double vision. They're talked about a lot, but I actually find they're quite rare. We're talking about headaches, particularly middle of the day, end of the day, eye rubbing, complaints of sore eyes, watery eyes, getting close to the page. They're all things that might seem, where we could quickly make the connection that it might be a vision or an eye related problem. Probably the ones that really get overlooked are falling into that performance category where someone might avoid reading, they might lose interest, they might say it's boring, they might find that they can do the first paragraph or even the first page and then the performance seems to drop off. Or you get someone who is sailing along well all of a sudden and then quite rapidly starts to kind of plateau and sort of peter out in their enthusiasm. And they can be blamed on lots of things, attention, laziness, even. Unfortunately, that still gets bandied around occasionally. And even just interest. Oh, it's just not their thing. And it's interesting to sometimes test an adult and the kind of workups I do on kids, I do on adults because they carry their problems from childhood. And I'll sometimes say to a parent or an adult that I've got in the chair and say, you were never a reader. And they go, well, how do you know? It's like, well, I can tell from the way that you use your eyes that you would find reading uncomfortable and difficult and would lose concentration and therefore you won't enjoy it. And why push at something that's not enjoyable?
So do you think that a lot of times these kinds of vision issues get misdiagnosed as like ADHD or dyslexia or something similar?
Look, I think it's a complex issue that's not easy to answer. So I think there's certainly a small group that do that just have vision problems getting in the way of their learning, where that is the only reason. And they're the group that when you manage the vision problem through an appropriate set of glasses or doing vision therapy, they just take off. And you kind of go, well, it was never a learning problem. It was never a reading problem. It was never dyslexia. They just had a vision problem. And I don't know if you I like the Wallace and Gromit TVs the shows, and there was the one where they were going to the moon and to get some cheese, and they've got the rocket, they've built it, and they're all ready for takeoff, and the rocket's shaking, and they're kind of looking at each other and wondering why the rocket hasn't taken off. And Gromit looks down and takes the handbrake off, and all of a sudden the rocket shoots off. And it's kind of like that with some kids where you get this remarkable change from a fairly simple thing that you've done because they were like that rocket just ready to go, but they had the handbrake on, which was, a simple vision problem.
Mm.
But to take that a little bit further, if you look at the attention deficit populations and the kids who might have dyslexia or reading problems, the research seems to indicate that they are more likely to also have vision problems that are hindering them. So they've got what we like to call a comorbid problem. And any human being deserves to have good vision. So we have a role to play in helping remove the visual barrier to their recovery, even if it's not the primary cause of their diagnosis. So I think it's a really important thing that we're assessing vision across all of those. And the way I look at it, if you've got a reading problem, you are doing more work than everybody else. You are probably someone who needs the removal of a vision problem the most, because you're spending more time and more work on your recovery.
Okay. Well, let's get into some of the specifics of how you remove that handbrake. So I'd like to talk a little bit about your philosophy of behavioral vision care and how vision therapy fits into that, and maybe like some of the specific things that you do in your practice.
Yeah, and look, and people get confused around the label behavioral optometry and behavioral vision care. And I had a teacher say that it's the way I explain it to the parents is that it's we look at visual behaviors, and we look at how vision fits in with what you're trying to do. Vision is what guides your movement, and it's your master sense when it comes to sort of learning. So we have a look at how someone moves their eyes, how they focus, how the two eyes work together. And importantly, can they do those things easily without having to concentrate on it? Because if you're having to concentrate to keep the two eyes working together and keep things focused, that's concentration you don't have for learning. And if we catch a vision problem in the early stages of eye strain, then sometimes I like to call, we might prescribe the ergonomic chair for the eyes. So if we have a look at ergonomics as an industry about making us more comfortable when we're in an office environment, well, why is that? Well, again, we're sitting still. We're not designed to sit still forever. So we have to sort of create desks and chairs and keyboards and mouse and screens. I've got a curved screen here, which is meant to be better for ergonomics. It's a way of helping our bodies be in a more comfortable position. And I don't think the visual system is any different. And so sometimes we can use very mild lenses to help with kind of like a visual ergonomics to take the strain away, digital eye strain, even just eye strain from reading. To take it further, though, if someone never developed the good enough skills to begin with to be able to manage the pressure and the demands, the visual demands of modern schooling and classrooms and learning, or it deteriorated because of that strain and we just didn't pick it up early enough, then we can use vision therapy to retrain those skills. Vision is something that we're obviously born with the potential, but we need a lifetime of learning and development to learn how to use it. It's a bit like learning how to use your arms and your legs and your hands and your mouth. We need to learn how to use our eyes. And so if it's something that can be developed as a skill, it's something that can be retrained and helped developed in a very programmed, systematic way to either rebuild skills or provide skills that didn't quite get there to begin with.
So I know there are like some computer-based, training apps. I think that can help to a certain extent. I've seen people talk about pencil push-ups. I think that's like, I know what a pencil is. I'm less familiar with push-ups, but it's like that kind of thing. But there are probably other types of training programs, therapy programs that your practice does. Can you?
Yeah, look, there was a pretty solid bit of research done over a good 10 to 15 year period that really showed that those basic kind of activities might be well-meaning, but they're not very successful in providing the sort of change and symptom relief that people need. They're just too simple. It's a bit like seeing someone with a limp and saying, please stop limping, without removing why they limped or really showing them how to walk straight again. And so those simple kind of activities really aren't that effective. And so we tend to use what we call an office or clinic-based vision therapy approach, where it's like personal coaching for the visual system. You're working one-on-one with a vision therapist to really understand how your vision currently works, understand a way of developing better skills, and then having someone coach you through the process of making those new skills a habit so that you own them. And then when we're done, that you hang on to them, and they just work in the background. So you've now got a visual system that's working without you having to think about it. And so it's a very hands-on approach at developing visual skill.
And so in the case of children, like, parents obviously play an essential role in that whole training treatment program.
Absolutely. So obviously we're training the parents in order to, it's a journey to understand how vision impacts on their child's ability to learn and study, and maybe even affects their coordination and ability to participate in sport. But the reality is that we do need some practice to make it stick, and so the parents are involved in delivering the therapy at home with guidance from our vision therapists on a weekly basis.
All right. Well, we touched a little bit on screen usage, and I think we're both Gen Xers, and I think our experience growing up was a little bit different to teenagers today. We
Yeah,
didn't
absolutely.
didn't have YouTube in our day,
Yeah.
and so this is something that I'm dealing with at the moment with my own family, my own kids. So I know that like a lot of optometrists talk about the impact of screen time on myopia, and we'll talk a little bit more about that soon. But I think there are some other impacts as well, aren't there? There's some other issues related to screen time that we need to be aware of. Can you talk a little bit about that?
Yeah, absolutely. Absolutely. It falls into a number of categories. And so probably the easiest one is to kind of go, well, the studies are showing about 80 to 90% of people have digital eye strain. And you kind of
Mm,
go, well, that's immediately showing you. And people go, well, if so many people get it, isn't it just normal? And you're kind of going, well, if 90% of the population becomes obese, are we happy to say that's normal as well?
mm,
Not really. It shows that these modern devices aren't really good for us, and that we need to be really sort of careful. So again, a flat two-dimensional surface, not moving, held at a close distance, is really not what our visual system was designed to be used for. And so we're going to get fatigue and fallout and those sorts of things. So you're going to get eye strain. Sometimes you may not even notice because what we look at on the screens captures our attention.
mm,
It's a bit like those kids who can play video games for hours and only realize their eyes are sore once they're finished because their attention is so drawn to whatever's on the screen. So you've got that development of eye teaming and focusing problems that is impacted, that is occurring during an enjoyable task that then might go and impact them and be left over as a bit of a hangover for when they need to learn and study and actually use their eyes while they're concentrating more heavily. So you've got that side of it. You've obviously, with myopia is increasing in prevalence, and we'll chat about that. But for the younger kids, there's also that opportunity cost. Um, the way you develop an imagination is by exploring the world around you. And what a screen does is it captures your attention. It provides the experience rather than you developing the experience yourself. And it's in a very limited format. And so it kind of feeds you a way of thinking so you don't develop your own thinking skills. And there's
mm,
also that loss of social communication, even from the parent being on the device
mm.
when the child's doing something and you miss that opportunity to make a connection and eye contact. I think there's a whole communication loss as well. So it goes very deeply beyond just eye strain and myopia. There's a whole social, emotional, and possibly some forms of intelligence that we're going to be missing out on through devices. Not only the kids using it, but the parents missing out on opportunities from their use as well.
Yeah, yeah, I do feel that we're sort of all in uncharted waters here when it comes to digital
Absolutely.
screens and how
Yeah.
that's going to impact on us as a society. Even. And I think maybe like one of the other things about a lot of screen time, and I'm hearing more and more about this, is dry eyes, like dry eye syndrome. People seem to be more and more complaining about dry eyes. I think like I've got dry eyes myself, and I'm sure a lot of that comes from just looking at the screen and like forgetting. You don't notice you're doing this, but I think you forget to blink, or you don't blink
Yeah.
completely sometimes, and that has an impact, doesn't it?
Yeah, and there's a few layers to that. So you can get dryness symptoms from eye strain, and so I do see people diagnosed with dry eye who actually don't have dry eye. It's eye strain. Um, then you do get people whose eyelids, where the oils that make a good tear film come from, are in good condition, but as you say, they're not blinking enough. And when we look at a screen, particularly a computer screen, it's elevated. We don't blink as often when we're concentrating. So long drives, computer use, device use, we don't blink as much. We often do a little half blink. So the bottom half of the eye remains exposed to dryness. And then if we're doing that in an air conditioned environment, it's even worse. And the little oil glands in your eyelids actually need the full closure for those oils to spread out across your tear film. So you've got that lack of of a complete blink, not enough of them, and then we're not getting a good quality oil going across. And that's one of the thoughts behind why we're starting to see kids with actual impact to dry eye problems on their eyelids, because those oils aren't being expressed. And so they tend to have the glands blocking up effectively. And we're certainly seeing that kind of problem that we normally associated with people of my vintage and your vintage now, a generation earlier. Yeah, absolutely.
All right. Well, let's talk a little bit about myopia. So maybe first of all, what is it? Because I think when a lot of people hear myopia, they just think, oh, okay, that's short-sightedness, right?
Yep.
And maybe a lot of people will think, well, okay, so you've got to wear glasses, big deal. We all end up wearing glasses at some point. What's the issue, right? But there are like more health implications behind that, aren't there? So like, tell us like
Absolutely.
what is myopia, and why should we think about this seriously in relation to the eye health
Yeah,
of our kids?
absolutely. So, we call it myopia, short-sighted in America. They tend to call it nearsightedness, and the name gets confusing. People confuse short sight and long sight, and that's where it's nice to have the actual proper label out there, starting to become part of more of the common language. And so, um, we are generally not born with myopia. We are generally born more on the hyperopic or long-sighted end. And myopia is something that increases in prevalence at around school age. So the number of people who become myopic, it becomes a lot more. So the whole average prescription sort of starts to lean towards that short-sightedness. And often the first conscious signs of being short-sighted is you start not being able to see as clearly in the distance. And it could be that the things are blurry, or it could be that the person next to you is laughing at a sticker on the back of a car and you can't see it. That's what happened to me. But you were sort of unaware of it because it sort of crept up on you. And it used to be a thing that, when I started in the profession, that, if I had a young person in my chair who was short-sighted, I could almost guarantee that the parents were short-sighted. Whereas now I think they're predicting the Brian Holden Vision Institute looking at some of the statistics, and they were looking at 50% of the world's population being short-sighted by 2050. And if you have a look at the American story, back in the early 70s, there was about a third of the population were short-sighted. They're now up to 60%. We're kind of sitting in Australia where America was back in the 70s, where we're about a third, but they're predicting that we'll kind of hit that 50% mark down the track as well if things keep continuing. And you kind of go, well, where's this all coming from? And I'm certainly getting parents in now with bringing their kids in who are becoming short-sighted, and there is no family history. So something's shifted. Obviously, you can have genetics, but they talk about nature versus nurture. Nature being you picked the wrong parents, nurture being what are you doing with your eyes where they change. And so short-sightedness has been linked to a lot more indoor time versus outdoor time, intensity of near work. We have a look at why has Australia escaped it for so long? Well, we've got an outdoor lifestyle, we've got more access to greenery, less built environments, but we certainly still got that pressure with devices. And so when you become short-sighted, the eyeball starts to grow longer than it should, and that throws the optical components out. So it maintains near vision, but you start to lose clarity in the distance. And if you go and get a correction done to restore how clearly you're seeing out in the distance, that does nothing to stop that process of the eye getting longer. Now, if the eye is getting longer than it should, then it's going to start to create sort of stretching and other things in the eye tissue itself. And so the concern is if it's allowed to get to a very high level of eye length and therefore high level of myopia, that you have a higher risk of other eye diseases as an adult. So things like glaucoma, where the pressure goes up in the eye and damages your nerves. You've got risks of retinal detachments, and you've got a higher risk of getting cataracts earlier than other people. For very high short-sightedness and myopia, you've got the macular degeneration. So we're looking at improving the outcomes for kids for the decades to come in their adult life. So that's that early intervention.
Right. So myopia leads to not just short-sightedness or nearsightedness now, but you might be setting some time bombs for like decades in the future when
Absolutely.
when
Yeah, yeah.
these types of eye health things actually come to fruition.
Yeah, it's not just the inconvenience of not being able to see. Yeah,
Yeah.
absolutely. Yeah, yeah. And
So
there are things we can do about it.
right. Well, let's talk about those. So, like, what are some of the treatments available for myopia? Like, and is it possible to actually stop myopia, or is it possible to slow it down? And like, what are some of the treatments that you found are really effective for doing that?
Yeah, so there's a lot of research in myopia, and with any sort of research, it's very difficult to say something. You got to be careful saying something causes something else, and you have to have a huge amount of research to be able to get a direct causal link rather than just saying something's kind of associated. But they now are brave enough to say that lack of daily outdoor exposure is a cause of my early myopia development. And so one of the things that I'm coaching my parents on, particularly if there's a family history, if they're worried about what their kids are doing with screens and indoor time, is that you need to be spending 90 minutes per day or more outside. Now, that doesn't mean you won't become short-sighted or myopic, but it delays the onset, because the older you are when you start becoming short-sighted, the slower the progress tends to go, the less myopic you'll be as an adult. And so lifestyle choices are a big one that I don't think we talk about enough. Limiting taking breaks from near work, 45 minutes is kind of a maximum. Hop up, move around for 5 or 10 minutes. Don't move from one screen to another one. Don't move from a book to then the phone. Get up and move, and preferably outside. If we get to the stage where the horse is bolted, as the cliche goes, that we've already started the path of being myopic, then we can use different optical tools to inhibit that growth and inhibit that process. So one of the leading techniques we have is the ortho-k or orthokeratology. We also have multifocal soft contact lenses. We now have new spectacle technology, and there's also some drug therapies that help with trying to slow down the growth. Now, we can't stop it necessarily. The indications are that, it depends on which bit of research you look at, but anywhere between a quarter to a third of people may stop in their progression when we intervene with the right tools, but the rest will still progress, but hopefully at a slower rate. And so the overall stats seem to suggest we're able to get a 50 to 70% slowing of progression in eye length and prescription by using something other than just sight correcting glasses.
Okay. Now, I don't want to get too much into the weeds here, but I understand that with the lenses, like some of the glasses and the brands that are available now for myopia control and contacts as well, they kind of work through a mechanism of creating some sort of defocus within the eye. Is that right?
Correct.
Can you explain that for us?
It all comes down to what the optics are doing on the outside of the eye. And so I'm not sure if it's a good time for me to maybe grab a model and I can point at it. So I'll,
if you like,
we'll see if we can make that work. I'll go and grab one. Okay. So if we have a look at the model eye, basically we've got a tiny little spot here called the macula, and that's where we are conscious of whether we're seeing blurred vision or not. And so that's what we're making a decision on whether you can see clearly when we're doing a prescription lens to restore clarity in the distance. But when we have a lens, it's putting an image across the entire back of the eye. And this is the important part, that if we're using a lens that's just designed to make this clear, it puts the wrong kind of optics in the periphery here. Okay. So if we can use a lens that says, okay, we're going to keep this part clear, but we're going to put a different type of focus out in the periphery, then it flicks a switch on the growth mechanism. So we can control how the eyeball changes shape by changing the optics, because the retina is just a bit of brain tissue that we point at things. So it's actually processing what the light's doing. So if we're able to apply a different focus in the middle compared to the outside, that's how we control the growth. And really what kickstarted a lot of it was the ortho-k, which was an accidental finding where
Mm.
we were using ortho-k to restore clarity of sight to adults. I've been wearing them myself for 20 years, just as my choice for being able to see clearly. We used to sort of talk about it as an alternative to laser surgery. It's non-surgical. You're not wearing contacts during the day, et cetera, et cetera. And as we got more comfortable with the fitting techniques and they became easier, we started fitting younger and younger people. We noticed that teenagers and children who were fit with it, anecdotally, the clinicians who were doing this in the early days, we were saying, hey, do you notice these kids aren't progressing like the ones that we are prescribing glasses to? And there was enough of us making enough noise about it that the clinician, that the researchers are then were able to start looking into it. And then they discovered that just one of the sort of side effects of ortho-k is it created this dual focus. And so when they've recreated dual focusing in contact lenses and spectacles now, they're getting a very similar effect in being able to slow down progression.
All right, well, let's talk a little bit more about ortho-k, because I think it's an amazing technology, like you've described a little bit there. The way I kind of think about ortho-k is like you're putting these lenses, these contact lenses, into your eyes before you go to bed, before you go to sleep, and
Yep.
then overnight it kind of acts the same way as like my daughter. She wears like braces, like a dental retainer, and they kind of straighten her teeth overnight. Ortho-k lenses work a little bit the same way on your cornea, don't they?
Yeah, and because the corneal tissue is just like skin, effectively, it's just a very specialized type of skin. It's a lot more flexible than our teeth. So you wear braces, then you get a very slow, hopefully not a rebound effect. Whereas with the eye, you're getting this temporary sort of flattening of the skin on the front of the eye, and it's much like if you wear, watch, jewelry, our clothes might leave a small mark on our skin. It doesn't hurt to have that done. We don't really feel it happening. The mark that is left by those things takes a very short time to create, but takes a long time to kind of bounce back to shape. We're just taking effect of that when we use a lens on the front of the eye. So effectively, where the cornea is the main thing that changes the optics, is the main lens of our system, and so it's very curved, and so it only takes small changes in the shape of this to make a big impact on how the light's focused at the back of the eye. And so we use lenses that are specially shaped on the back of the eye to just gently flatten the front of the eye while you sleep, and that rebound back to its normal shape can take a couple of days. And so we're able to get at least a daytime of being able to see clearly once we take the lens out in the morning. You wear it every night to every sort of second night as an adult. As kids, with kids for myopia control, we say, look, wear it every night. But some adults might get every second night and still maintain pretty good vision, even on the days that it's kind of skipped. And it sounds a bit too good to be true. It's one of those things that a lot of people don't believe. I've got my practice is now 21 years old, and we were one of the first practices on the Gold Coast doing ortho-k, and I've still got patients from back when we started, and I've got one of them who says, I tell everyone, but it sounds too good to be true. They just don't believe me that it's that it can work like that, but it is really simple in theory. There are some complex mathematics behind it, but it's a lens that you put on and sleep, and then when you sleep, and then when you take it off, you've got that impact and effect. I mean, I guess we need to be careful. It's not for everyone. We need to make sure that your prescription range is in the one that we know kind of works, and there are other eye health things that we need to check. But it's one of our great tools for people looking for something other than glasses. If they find contact lenses during the day uncomfortable, they can still be a candidate for ortho-k because you're only wearing the lens while you sleep. It's not impacting on dryness during the day.
Yeah. So a lot of people who find that contact lenses generally, like daytime contact lenses, aren't for them because they do have dry eyes. Ortho-k might be a great alternative because you're literally only putting them in overnight and taking them out when you wake up, right?
Absolutely, and that's what led me down the path of wearing it myself, and that's how I got interested in actually doing it. I had a colleague who was getting interested in it in the early days, and he said, "Oh, would you like to try them?" And I said, "Sure, great." And it was a way of I was surfing a lot back in those days, and not comfortable in regular contact lenses all the time, and certainly glasses are a bit of a nuisance. So it allowed me to get back into cycling and surfing and other activities without having lens and without having the dryness.
Yeah. And swimming with contact lenses is problematic in itself, isn't it?
Absolutely, and basically you've got the higher risk of bacteria sticking to the contact lens, and so you need to be very cautious around that.
So what sort of age ranges are we looking at here who would be good candidates for ortho-k or orthokeratology?
Look, it's a funny space at the moment too, because we started out fitting adults, and it was a product that was for grown-ups, and when I now have parents asking if they can have it because we're fitting a lot of kids and teens with it, and so I'm going, well, actually it started out as a product for adults and then became a great tool for myopia control. And there are they do show that if we put ortho-k as a special kind of contact lens, and then we look at the contact lens sphere generally, kids are actually quite good with contact lenses, and in fact have a better go of it than young adults. Your sort of high risk group for infections are the 19 to 25-year-olds. In the teenagers and kids tend to be a lot more responsible. There's a lot more parental supervision, so they can actually be very good contact lens candidates. So certainly teenage years is relatively straightforward. We've got kids as young as 6 or 7 wearing ortho-k, but they've got to be ready and a willing participant as part of that. So we're not going to fit it to every 6 or 7-year-old, but that could be as young as that to a motivated child, and they understand what they're doing it for. And that typically is about where we start.
That's probably the only caveat I think with ortho-k, isn't it? That like there is you do have to have a commitment to cleaning, a daily cleaning regime.
Absolutely.
So it's not like it's not like the daily disposables where you just throw them in the garbage and pick out a new pair. So you really do have to take care of them and be sort of mature enough to stick to that.
Absolutely, and you look at all contact lenses carry a slight increase in risk in eye infection compared to just wearing glasses, and those risks are quite small. A lot of them are around water and dirty cases, and so sticking to hygiene and sticking to the rules about avoiding water with your contact lens is the number one thing. But yes, with ortho-k, you're having to clean and look after it, and again, children typically develop good habits that are being supervised compared to young adults sometimes.
All right, Paul. Well, I think this has been a really informative discussion. So we started off talking about how good vision is not the same as clear sight, and we've been down a few rabbit holes really to talking about that. Do you have anything else you'd like to add before we finish up?
No, I think we've like you said, I think we've covered it a lot, and
Right.
certainly been down some rabbit holes. So yeah, no.
Excellent.
I just really appreciate the opportunity to talk about our master sense. It's I think people really we take it so for granted. Yet at the same time, we talk about being our most precious sense. It's this weird dichotomy of kind of saying, okay, it's our precious sense, but then we kind of ignore it.
Yeah.
Ignore how wonderful it is and how powerful it is and
Exactly.
how much of a difference it makes in our lives.
That's right. You take it for granted until you start to lose it, I guess.
Yeah, absolutely.
So, okay. Well, so how can people get in touch with you and get in touch with Harmony Vision? Tell us how that we can do that.
Okay, so the full name of the practice is Harmony Vision Care. So it's harmonyvisioncare.com.au. And so we have our details on the website. There's the ability to book online through that. If people want to have more of a discussion in when they're making an appointment, then they can give us a call on 0755205900. There's also contact us forms, ask the optometrist a question, and email links on that website as well.
And you're located at Varsity Lakes on the Gold Coast, is that right?
Yeah, so we're just sort of it's south central part of the Gold Coast, not far from Robina and Burleigh Waters. You know, the Gold Coast is a fairly easy place to travel. We tend to get people from the northern rivers and the northern parts of the Gold Coast, as well as those located around us. We've become a bit of a destination practice because of the work we're doing.
Good, good. All right, well, we might finish here then. So, so again, thanks a lot, and I'm looking forward to having more discussions like this in the coming months. So for now, I think let's leave it there. So thanks very much, Paul.
No, thank you. That's great. Cheers.
Bye-bye.